Hi, everybody. Byron Wine here. And today I'm going to talk about behavioral safety in healthcare settings. So, behavioral safety has a long history of being effective where applied, and it is been seen in construction and oil refineries, a lot of different places, but not very often, surprisingly, in healthcare settings, at least from a behavior analytic perspective. So that's not to say there's not a problem or that injuries don't occur. In fact, if you look at the recent data from the Bureau of Labor Statistics in 2022, there were 2.7 injuries per 100 full-time employees on average across all private sectors. And in specific, because it's an average, obviously, in specific sectors, you would expect more injuries, and that is the case. If you look at child and youth services, it's 3.5. It's 4.5 in healthcare and social services. It's 6.1 in hospitals, and an astounding 9.4 in nursing and residential care. In fact, if you drill deeper into that, like skilled nursing homes, it's even higher, much higher. So in terms of behavior analysis, relatively little research and applied work has been looked at decreasing injuries to employees in these settings. And obviously, behavior analysis is not large enough to have its own kind of subcategory in the Bureau of Labor Statistics. But you could argue, depending on where one practices, we fall into one of these categories. And it wasn't until recently that we began looking and surveying practitioners to see what was causing injuries. And perhaps unsurprisingly, it's the interaction with the clients that we serve, usually as they engage in aggression or some other problem behavior. That is what's causing injuries, typically bites and scratches to the extremities. And if you look at all the other categories, the one thing that they all have in common is that they are serving other individuals, oftentimes with significant needs. So it's that interaction between other individuals that's causing the injuries. Now, NIOSH has a kind of recommended hierarchy for decreasing injuries in any setting. So one of them is to just simply eliminate the threat. So if you're using a hazardous chemical and you don't need to, you just shouldn't use that. That makes sense. I guess from a hospital or a behavior analytic or a skilled nursing home, you could just discharge the clients, although that's not really an answer. You can't just get rid of a patient who shows up to the emergency room because they're engaging in problem behavior. It's not exactly how it works in a lot of settings. And in skilled nursing homes or behavior analytic practice or education setting, probably the real answer is to conduct good clinical programming and decrease the problem behavior over time. Now, that's the answer. However, I would argue you still need something in place while we're waiting on the problem behavior to decrease. And even if there's a clinically significant decrease in said problem behavior, it's still likely to occur every once in a while. And so the risk of injury is still going to be present. The next is to substitute, so if you have to use a hazardous chemical, maybe there's something less hazardous, then you can use less caustic. There's not really a good method of substitution in a lot of health services. I guess you could say you can enroll specific clients, but again, that's not really how it works. Teachers don't get to choose who shows up to their class by and large, and emergency rooms can't pick and choose who shows up for treatment. The next is to engineer. So if you can't get rid of the caustic chemicals, maybe you can build or engineer your way out of it. Install splash guards, and there is some work that we can do here. For example, we have clients who target windows to break the windows. We might be able to install polycarbonate windows or something else so that they cannot be broken, or pad surfaces or something of the like. The next two recommendations, kind of the things that you should consider after you've done all of the above, I consider kind of as one, which is administrative controls. These are safety programs and personal protective equipment like jean jackets or something. I consider them both the same thing, because you can provide jean jackets, but if people aren't wearing them, then they're not going to do anything. So they might need to be a part of a behavioral safety process. And indeed, in practice, I've had to target that. Jean jackets are very effective, for example, in decreasing scratches and grabs and clothes getting torn and stuff like that, but they're also hot. People don't want to wear them sometimes. So we've had to target those. Now, going through the entire behavioral safety, or sometimes called behavior-based safety process, is certainly well beyond the scope of a short video like this. These are the general steps I'm going to layer on the screen. There's a lot more to it than that. I recommend Terry McSween's book for this. Scott Geller has also written a lot of good textbooks on behavioral safety process that people can look into if you want to learn the whole system. But one of the things that I think is most interesting in all health and human service kind of jobs is that I don't think it's possible to completely get rid of injuries, or I think that you can decrease them significantly. I think that we can decrease the severity of injuries through good behavioral-based safety or behavioral safety programs and good engineering and good clinical programming. But as long as you have another individual specifically targeting staff for injuries, whether that's an emergency room nurse being targeted by a staff member, or somebody's skilled nursing home being targeted by an individual, or having to catch an individual when they slip and fall, or somebody in a behavior analysis clinic working with somebody who's continuously targeting them for biting, it's unlikely you're going to really be able to get the injuries to zero. Especially when you consider the fact that no matter what we do, nothing we can do can put the client at risk of injury. Nothing we ask of the staff can be beyond the physical capabilities of the average staff member. That is, whatever the minimum physical requirements are for the staff to work there, that's what we do. That's what we can recommend. I cannot recommend lifting or moving or jumping or anything that's too physically extreme that people couldn't do, right? We also don't have a lot of time in these settings. Some industries are able, they have the time and the money to afford, whole safety committees and lots of safety initiatives and big time, lots and lots of time and energy. A lot of times in health and human service fields, we just don't have that. And then we are left with a very specific problem, which is key to any behavioral safety program, is you have to identify targets. Right after the safety assessment, after we've gotten rid of or engineered out things that are unsafe and done as much as we can, we are going to have to target some safe versus unsafe targets for employees. And exactly what are those? And when we looked into the literature, we didn't find a lot. So one of the things I'll show you today is kind of our first attempt to say you're working with somebody who's engaging in some problem behavior, or they're agitated and might engage in some fairly significant aggression or self-injury. How should you deal with that? Or what actual responses could you engage in? The first that we wanted to evaluate was this idea of distance management. You can see Beth, my colleague on the left, is standing relative to me on the right. And the first thing we wanted to teach was, if somebody's showing signs of agitation or they're threatening aggression or something, you should stand more than 2 arms lengths away from that person while you're engaging in whatever de-escalation or behavior plan that is written. Or you should stand within 1 arm's length. Where you should not stand is that 1 to 2 arms lengths, where if I were to reach out and grab or strike, I could cause some serious injury very quickly. The second thing we evaluated was this idea of a bicep check. So Kim is on the left. She is making a C shape. It's a little hard to see there with her hands. And Elizabeth is the posing as the client on the right. Kim is not squeezing her arms. She simply made a C shape, and she's putting that C shape over Elizabeth's biceps on the right. And she would do this as she continues to engage in whatever de-escalation was appropriate for the situation. Why would Kim stand so close? We would prefer to be far away, but obviously sometimes it's a small space. There's other clients that you just can't allow to get injured. You have to be close. So the reason that she puts the arms over there is in case, as you can see in the picture there to the right, Beth all of a sudden engages in some problematic behavior, tries to grab hair or hit or something. That Elizabeth on the left has a second or two to follow her arms with that C shape, again, not squeezing or grabbing, but to allow someone to avoid that injury. Now, there are a few more things that we've evaluated, but this is the basic idea: putting distance management, making the C shape, following the arms around with somebody. So we wanted to evaluate this. This is what we taught to some staff members that we were working with. You can see that in simulated aggression, which is me wearing safety mitts, going about half speed, trying to touch their head or torso, that in baseline, I was able to strike them quite a bit with these simulated strikes. They were landing upwards of 80–90% of intervals. And the actual safety procedures that we taught, things I just reviewed, they are the triangles there, and they were very rarely used in baseline. After the training, we did a little behavioral skills training. They were able to use the safety procedures, and the use of those safety procedures did dramatically decrease my ability to land these strikes on them. We then probed in the actual environment. All three of these staff worked with individuals who occasionally engaged in aggression. One of the staff on the bottom, you can see there, Corbin, did not actually experience any verified instances of aggression during the probe period, which is good. The other two did, and they were indeed able to use the safety procedures to decrease the actual strikes making contact with them. So, kind of some initial evaluations, but the point is, to have a behavioral safety plan, you need something to take data on to see if people are being safe. And in addition to safe lifting, distance management, use of gait belts, for example, we developed and kind of got a couple of targets that people could use if somebody's going to engage in aggression. Obviously, we didn't expand this work yet. This is relatively new to places like special education teachers working on their own, emergency room nurses, which are a group at high risk, along with psychiatric nurses of being targeted for aggression, or those who work in skilled nursing facilities and other places where they are likely to be the recipients of aggression from the clients that they are there to serve. This line of research is important. In the future, like I said, it's long been sort of overlooked in that if you were working in the field, you were just expected to get hurt. That is an unfortunate point of view, and we need to, I think, change that so that in the future people see that we are keeping them as safe as possible. And just because you choose to work in an industry that injuries are possible, more likely than the average, that we don't just leave you to the wolves and let you fend for yourself. It is our responsibility to provide a safe work environment, and I think that we owe it to the people who work for us and to our colleagues to help create a more safe atmosphere. So that was just a brief look into some of the things that we're doing and safety in healthcare and human service settings. I think that there's going to be work in this, hopefully in the future, and career opportunities for people. And if nothing else, just good practice for people when they're out to follow along with this literature. And if you find yourself working with individuals who engage in significant problem behavior, that you can begin to develop tools to keep yourself and the people who work with you safe. Thank you.